Professor Mullens received his degree in cardiology as well as cardiac rehabilitation in Belgium and graduated as advanced fellow in heart failure and cardiac transplantation and electrical therapies for heart failure at the Cleveland Clinic, Ohio, USA. He also received the degree of Doctor of Philosophy at Netherlands. He is a heart failure clinician with a strong commitment to translational research. Main research topics are cardiac resynchronization therapy as well as the cardiorenal interactions with more than 250 peer-reviewed publications. He has been president of the Belgian Working Group on Heart Failure and serving as board member of European Heart Failure Association. Over to Professor Mullens. Please take over, sir.
Good evening, everybody. It's still afternoon in Belgium. It's an honor to give this talk to you on pacing in heart failure with reduced ejection fraction. These are my disclosures, and I'll try to explain why and how I believe we should improve device care in our heart failure patients. And device care is really an essential part of care for our heart failure patients. I would also highlight these two new updated guidelines, one on heart failure, one on pacing and CRT, both been published by ESC, HFA, and ERA over the last year. They contain a wealth of documents, very interesting flow charts, very appealing documents for those who need to know more about heart failure and device care. So who needs the ICD? We have to bear in mind that in the Western world, the second leading cause of death is sudden cardiac death. So 1 out of 5 of people in my country die of sudden cardiac death. And it's important, of course, to identify the patient who has the highest risk for sudden cardiac death, because that patient might benefit for an ICD. So we always have to take into consideration when we assess patients for an ICD, what is their risk of sudden cardiac death and what is their risk of non-sudden cardiac death. And if the balance holds over to the sudden cardiac death, those are the patients, of course, that might warrant an ICD implantation. It's therefore clear that in secondary prevention, patients who survived a sudden cardiac death in the absence of a reversible cause of sudden cardiac death should receive an ICD if they still have a life longevity of more than 1 year. In primary prevention, the ESC has still a 1A recommendation for patients with HFrEF, so ejection fraction below 35%, on optical medical therapy if you have an ischemic cardiomyopathy. If you have a non-ischemic cardiomyopathy, there has been a downgrade to 2A indication for patients, therefore, who do not have ischemia. Now, we might wonder if this downgrade was actually correct. So let us look at the rates of sudden cardiac death in real life. This is a slide that many people show, and many people use this slide to actually tell that the rate of sudden cardiac death is actually declining. Well, if you take away the old studies, you could see that basically in the control groups, the rate of sudden cardiac death remains identical. It's still 3% every year in patients with non-ischemic and ischemic cardiomyopathy, primary prevention, even though you give them good medical therapy. So 3% of our patients with HFrEF might die sudden every year because of a preventable disease. And therefore also a very important study was the Danish study. So Danish was a study looking at HFrEF patients with non-ischemic cardiomyopathy without scar on optical medical therapy and without atrial fibrillation. Danish randomized patients to an ICD versus no ICD, and they stratified according to center and CRT. So bear in mind that almost 50% of this primary prevention ICD indicated group also received resynchronization therapy. As all of you know, the primary outcome of all-cause mortality was neutral for the ICD, meaning there was no significant benefit overall for all-cause mortality by implanting an ICD. However, the ICD halved the risk of sudden cardiac death in all patients. So how can you explain this discrepancy? Well, it has to do with the causes of that. Because if you're elderly, meaning over 70 in the study, or if you had advanced heart failure, your risk to die of non-sudden cardiac death was significantly higher than of sudden cardiac death, and therefore the ICD was of no benefit anymore in the elderly and in the patients with advanced heart failure. Also bear in mind that more than 50% of these patients also received resynchronization therapy, and resynchronization therapy, of course, might have reduced the effect of the defibrillator. So take into consideration that if you add CRT to this ratio, that the ratio will change. And there's this unanswered paradox. CRT reduces the need for ICD, we know that, but improves survival, reduces the rate of heart failure, and therefore it exposes your patients to an increased duration of life in which sudden cardiac death can occur. I mean that if your risk of sudden cardiac death goes down from 3 to 2%, the defibrillator might not be of benefit in a group of 2,000 patients at 4 years, but if they all live longer, eventually most of them will still need the ICD. And if you look at our data, for example, these are data from more than 600 patients where we looked at our own CRT groups, where we defined CRTP, CRTD, primary prevention, non-ischemic, ischemic, and secondary prevention. You could see that if you select patients well, that patients also with the CRT will have a lot of sudden cardiac death, especially if they have ischemic cardiomyopathy. So when we wrote with HFA an update document before the guidelines, we stated that there was no evidence to change the guidelines for ICD implantation in HFrEF patients with coronary artery disease, but clearly one may consider not to implant an ICD in patients with non-ischemic cardiomyopathy if they're elderly, if they have advanced heart failure or life-shortening comorbidities, or are likely to die for reasons other than sudden cardiac death. Now, what about resynchronization therapy? Should we consider resynchronization therapy as a pivotal therapy for HFrEF with a wide QRS? And the answer is definitely yes. Why? Because patients feel better, they're hospitalized less, they live longer, they have less fast deterioration with a not too difficult technique at an acceptable risk and at an affordable price in Europe. However, CRT has been approached with an unprecedented scrutiny, despite its firmly established benefits on morbidity and mortality. And we have to wonder, why is that? Why are physicians and patients so reluctant to undergo this life-saving, quality-improving device therapy? And I think one of the reasons is that we feel that a device should cure a disease. But that rarely happens. Only 5% of our CRT recipients have actually this spectacular improvement in LV function. So complete reversal of the heart failure phenotype occurs in 5% of the CRT recipients. In those patients, it's even possible to gradually withdraw medical therapy because the disease has been cured. However, in 95% of the cases, CRT will not cure heart failure, but it will just ameliorate heart failure. It will provide disease modification. And we need to ensure as physicians, as medical teams, that we can get the most out of the device in order for the device to improve outcomes maximum. And if you look, for example, at all studies on remodeling, every study in CRT, which included patients with a QRS above 130 milliseconds, showed positive remodeling. There is no single randomized clinical trial in CRT that did not demonstrate improvement in LV function. Improvement in remodeling actually is related to an improvement in outcome. The more reduction you have in end-diastolic volume, the more improvement in heart endpoints on mortality and heart failure hospitalization we actually will see. CRT is such a spectacular therapy that it also improves cardiac contractility on a cellular level. These are data from our own center where we did myocardial biopsies pre and post CRT, and in most of the patients who had disease modification, we saw improvements in contractile function. That is one of the many reasons why we wrote this document. This is a document on optimized implementation of CRT, a call for action for referral, so meaning more implantations, and also optimization of care once the device has been placed. This has been a tremendous amount of work done by HFA, ERA, EACVI, and ESC to improve CRT care. And we have 4 action points that I would like to highlight. The first action point is overcome the underutilization of this spectacular device therapy. 30% of the patients with HFrEF have a wide QRS. That means that 1 out of 3 of the patients that you will see in your clinic have a wide QRS and might be amendable for improvement with CRT. The wider the QRS is, the worse the prognosis is. So the wider the QRS, the higher the likelihood is that that patient will die or will be hospitalized within the upcoming years. So don't underestimate the tremendous hazard your patient has when he has an increased QRS width. That's the reason why there's a strong recommendation 1A to implant CRT in patients with a wide QRS defined as a QRS above 150 milliseconds and left bundle bench block morphology with a low ejection fraction on optical medical therapy. We also strongly advocate placing a CRT rather than RV pacers in patients with HFrEF who are in need of RV pacing. We also think we should implant or should consider implanting CRT with a 2A indication in patients with non-left bundle bench block and wide QRS, or really wide QRS without the left bundle. Now, if you look at the uptake of device therapy in randomized controlled trials, and I look at Paradigm, looking at sacubitril valsartan, DAPA, and Emperor, both trials done the last 2 years, you could see that only 12% of the patients, including Emperor, had a CRT device. This should have been 30. Only 31% in Emperor got an ICD. Well, almost everybody had an ejection fraction below 35%. So that means that also in randomized controlled trials, the uptake of device therapy is far from good. If you look at real life, it's even worse. These are the implantation rates for CRT-P, D, and a combination in Europe per million inhabitants every year. And you could see that we are implanting about 150 CRT devices annually per million inhabitants in Europe. According to the guidelines, class 1 and 2 indications, it should be 400. So that means that only 35% of the patients that should get the pacemaker actually get the device. And we need to identify the barriers to referral for device. And there are many of them. I'm not going to go in detail, you can find it in the document, but there are many reasons why physicians and patients do not refer their candidates to a deferred device. I think we can improve identification of the ideal candidate. We can do EKG surveillance in your hospitals. You can educate, and you should educate your primary care physicians, your internal medicine physicians, but also patient groups on the benefits of device therapy. I'm going to address wrong myths surrounding CRT, but there are a lot of things that we can do to improve the implantation rates. The second point is to have a better interpretation of pre-implant patient characteristics, because there are a lot of myths, and myths are untrue stories related to CRT. And I'm going to go over some of these myths. The first myth is that CRT is too expensive. The ICER for CRT-P is 7,000 euros in Europe. So that's well accepted as cost effectiveness. So we should not be using money as an excuse for my or your poor healthcare organization. We should organize ourselves better to find the right patients that might benefit from CRT. The next myth, untrue story, is that imaging might allow appropriate deselection for CRT. A lot of people are looking at mechanical desynchrony. While this is of interest, this has never been used as an inclusion criteria for the big randomized controlled trials. We only use ejection fraction from the imaging side to select patients for CRT. So the absence of mechanical desynchrony should not defer the implantation of a CRT device in a patient with a guideline indication. That's not to say that imaging is not important. Imaging might help you to determine the choice between pacemaker versus defibrillator, and it might also help us to detect disease progression and guide auxiliary therapies. Another very important myth, untrue story, is that ventricular stabilization is a bad endpoint. This comes from the REVERSE trial. And what you could see is that the heart outcomes, heart failure hospitalization, all-cause mortality were also reduced in patients who had stabilized their LV function. Meaning you implant the CRT device, look at 1 year, 2 years, 3 years, you do not see an improvement in ejection fraction, but also no deterioration. That's similarly good as having an improvement in ejection fraction. This puts what we were thinking upside down. Halting disease progression is as important as improving the disease. You just want to make sure that the disease is not getting worse. But CRT in almost everybody halts a little bit the disease progression. Another myth is that CRT might be less effective in patients with comorbidities. Again, incorrect. If you have COPD and CKD or even elderly people derive as much benefit from the resynchronization part as people who do not have comorbidities. So we often implant CRT devices in elderly people with CKD. We don't implant the defibrillator, but we still resynchronize those patients. Another myth is that drugs are more important than devices. Bear in mind that there is very limited effect of drugs on LV remodeling in wide QRS. This is a study where we gave medical therapy to patients with narrow and wide QRS. And what you could see is that in a wide QRS population, there's almost no improvement in ejection fraction. In contrast, if you wait longer in patients with wide QRS to implant CRT devices, you see less reverse remodeling. That's one of the reasons why we as HFA took up in our new guidelines that you can consider CRT implantation sooner because the efficacy of medical treatment is limited in patients with LBBB. One of the most important still prevailing myths is that ischemic cardiomyopathy patients derive less benefit than non-ischemics. This is absolutely incorrect. In all the trials, ischemic cardiomyopathy patients derived similar benefits, even more than the non-ischemics, on hard endpoints like mortality and heart failure hospitalization. What is true, of course, is that the reverse remodeling response is significantly less in the ischemic cardiomyopathy patients. But as I alluded to previously, looking at reverse remodeling is important, but looking at hard endpoints is even more important. So if you can halt disease progression a little bit in the ischemics, that's already a very important endpoint as well. The other myth is that all CRT patients need a defibrillator. This is again not correct. How do we select patients for P versus D? And in my center and in a lot of European centers, we do about 50% CRT-P and 50% CRT-D. What do we look at? Well, secondary prevention favors the decision for a defibrillator. That's clear. An LBBB pattern favors the decision for a pacemaker. Having a lot of mechanical synchrony favors my decision for a pacemaker, just like comorbidities do, elderly people, CKD. Genetic mutations favor the decision for the defibrillator, and SCAR, especially on MRI, favors the decision for the defibrillator. So we use also patient consent, of course, we inform the patient, but there are clinical things that we as physicians can clearly assess to help us guide the best device for the best patient. The third action point is that we should get rid of the word response, and we should replace response by disease modification. When you look at patients receiving CRT devices in Europe, in over 11,000 patients, you see that these patients are very sick. They have high NT-proBNPs, a high prevalence of permanent atrial fibrillation, very dilated ventricles with significant MR. You cannot expect these patients to be cured with the device. They will remain to have heart failure. So your expectation should not be, I place a device and my patient will be cured. No, the expectation should be, I place a device, my patient will be a little bit better, but heart failure is a continuous disease. And I give you the example of the ideal patient, a female, white cuirass, LBB non-ischemic. Yet 1 year after the implant, she ends up in an ICU setting with cold and wet physiology, so high pressures, low cardiac output. By any definition, previous definition, you might think that this is a non-responder to the resynchronization therapy. Yet, if I turn off the device and I make a loop and you look at the septum, you clearly see the difference. So this is off, off, on, off, off, on. So immediately when you turn off the device in patients that you thought were non-responders, you see a drop in blood pressure, you see an increase in pulmonary capillary wedge pressure, and you see a decrease in cardiac output. So that means that patients who do not appear to have benefited from CRT, they deteriorate when you withdraw therapy. It means that the benefit of CRT is halted by a deterioration in the underlying cardiac disease. So CRT is again not a curative heart failure therapy, but it should be seen as a treatment to ameliorate the contribution of the synchrony, which will ultimately reduce heart failure-related morbidity and mortality. That is why we should compare ourselves with oncologists. If we would be oncologists, almost all of our patients would have a successful therapy because almost everybody will have at least a partial remission of their disease. Very few, if none, will have a disease acceleration. I actually have never ever seen a patient getting worse with CRT if we implanted a device in a white QRS phenotype. So don't think that CRT is doing harm if you select the patients well according to the guidelines, and talk about disease modification instead of response, because response always has a negative annotation attached to it. The final point is how to organize yourselves to make sure that every patient gets most out of his device. And this is the traditional outdated concept of device care. The patient comes in, goes to see his cardiologist, then goes to see somebody else to have his echo done, goes to see his electrophysiologist, his cardiac rehabilitation specialist. That's not the way to move these complex patients forward. I think we all should try to integrate heart failure and device care in one or two physicians, and they should be trained to integrate all of that into their minds. That is actually what HFA and ERA is advocating. We're trying to train medical and allied healthcare professionals in the holistic care of these patients who also have a device. And I feel that heart failure and EP should embrace each other to make a specialist that can actually be the gatekeeper of the device, but also be the caregiver of patients who have a heart failure and devices. Abbott is putting a lot of effort, just like HFA, into training the new generation of heart failure device specialists. And I'm going to give you the example here. This is an echo of a 25-year-old female living in Baghdad, Iraq, in December 2017. And as you could see, she has a very poor LV and RV function. Yet, she has been seen by Dr. Ghassan Mohamed Mahmoud, and he became a friend over the years because we trained him in a very interesting beating heart curriculum session where we actually do a modular training for heart failure or device specialists in the care of CRT. So we trained Dr. Mahmoud to place CRT devices in Baghdad, in Iraq. And look what happened. 2 years ago, her ejection fraction tremendously improved just by the placement of the device and by optical medical therapy. So what can we do after we place the device? Very important, push the disease-modifying drugs. There's always room to increase the beta blocker, the RAS inhibition, because the blood pressure is a little bit higher when you place a CRT device. It's the combination of medical therapy and device therapy that will improve your heart failure patient. Often you can reduce the doses of loop diuretics, and if needed, you switch from an ACE to sacubitril valsartan in the ACE progressors. Again, reducing the loop diuretics is often possible, and when you reduce loop diuretics, it gives you more room, more blood pressure to increase the disease-modifying agents. Take an EKG and teach your fellows, your internal medicine specialists, how to look at an EKG of a BIV-paced patient. This was an EKG taken when I was still in Cleveland of a patient included in Companion. Companion was a trial comparing CRT-P and ICDs, and what you saw is clearly a left bundle bench block, and it went unnoticed for 3 years, even in the Cleveland Clinic, which is considered one of the best clinics in the world. The patient had a lead fracture, and for some reason, physicians did not pick it up. Also train yourself and your fellow physicians in a device analysis. There are diagnostics in the device, measurements and programming things. And all of these things are very important. The percentage of ascends, V-pace, heart failure logarithmics, arrhythmias, impedance trends, how to program the lower, the upper frequency. All of these things are of pivotal importance if you want to help these patients better. Don't think we are doing a good job. This is real life data from Medtronic, where we looked at 80,000 patients for 1.5 years of pacing. 40% of these patients did not receive enough BIV pacing because of arrhythmias, which were not dealt with by the treating team. So remote monitoring will help you, should help you to do a better job in CRT delivery. Atrial pacing, less is more. Don't program the device at a too high basal rate. We never go above 50 because if you pace the atrium, you're going to induce atrial desynchrony, which will lead to more atrial remodeling, more mitral regurgitation, more atrial fibrillation, and probably also worse outcomes. AV optimizations. Try to get the best AV filling pattern. And the best pattern, the best delay, is the shortest interval that will dissociate the E and the A wave. If you turn on the device and you put it on 120, 140 milliseconds, 60% of the times you're right, but 40% of the times the timings are not optimal. So doing a quick look echo the day after the implantation might be of benefit. And you want to have the maximum separation of E and A. What we always measure is the QA time, meaning the onset of the QRS till the end of the A wave, because normally, mechanically, diastole lasts, even though electrically systole has started. A lot of things, therefore, can be done. This comes from a study we've done more than a decade ago in Cleveland, where we looked at the different things you can do to improve the outcome of such patients. It's taking care of suboptimal programming, arrhythmias, anemias, suboptimal lead position, suboptimal medical therapy, many things you can improve after the CRT implantation. If you do that and you take care in a multidisciplinary care program for these patients, they will do better with regards to hospitalization, and all-cause mortality. This is an algorithm that we published in the document I referred to. It's not a difficult algorithm. It uses very simple techniques: EKG, chest X-ray, device analysis, echocardiography. And then what about the future? The future of pacing might be conduction pacing. You know, we can screw in the lead in the bundle of His or in the LBB area. His pacing, of course, is something which is not really new. You screw in the lead at the level of the His and you have a really nice EKG. You can have selective His pacing or non-selective. Both are equally well because you're pacing over the native conduction system. His pacing is not so easy, and that is why people came up the last 2 years with LBB area pacing, where you actually screw in the lead very deep into the interventricular septum to actually reach the left bundle. When you do that, you also see almost a normalization of the QRS. Bear in mind, however, that there are a lot of problems related to conduction pacing. First of all, there is no specific pacemaker designed for conduction pacing. We need to document in the device and into the electronic medical record which lead is connected to which port. They often need individualized, difficult programming, especially with His. They have a considerably higher likelihood of dislocation of the lead if you consider His. Often we need to implant an additional lead out of safety, because we might feel patients will develop an AV block. Average fluoroscopy time, even in experienced hands, is 15 minutes, while with a conventional pacemaker, it's 2 minutes. And there are absolutely zero randomized double-blind clinical trial data. That is why in the guidelines, there are not a lot of strong recommendations for His pacing. There are absolutely zero recommendations for LBB area pacing. So bear in mind, there is no recommendation for LBB area pacing, only marginal for His. There is no recommendation for CRT because it still has to show at least equal benefits in terms of morbidity and mortality, and it has to show to be equally safe in randomized controlled trials before it can be used as an alternative to resynchronization therapy. So this is my final slide. The 4 pillars of better care are, first of all, overcome the underutilization of device therapy. Try to get rid of the word response, but use disease modification. Try to get rid of wrong myths surrounding CRT and offer a guide to a structured post-implant care. Final slide. Next week, we'll have a clinical practice update course on heart failure. It's also an online course on Thursday and Friday evening, and I would really invite you to join the course. It's a very low cost, and we have an update on heart failure. We tell you everything you need to be knowing in 2 half days about heart failure. I thank you for your attention, and I'm open for any questions you might still have.